House Direct Caregiver Training. I'm Amy Cooper, the clinical manager, and we're just going to go through some of the basics of our resident record documents and how we manage medications. For each resident record, we have a cover page that includes the resident's name, room number, the hospice name, and the contact information for that hospice so that we can reach them 24/7. We need to make sure this is accurate. The first page inside of the care plan or the resident record includes the care plan. This is going to have lots of information that should be really helpful for us as we provide care. It could be their name, date of birth, hospice agency, the hospice team information, their visitors, family members, friends, healthcare proxies, whoever else is important. There will also be anyone who should not have any contact or should not be allowed to visit. Of course, I will always let people know very clearly if there is anyone who we know is not allowed to visit for some reason. This also includes allergies, information about the resident's current mobility, elimination, impairments, dressing, bathing, skin, mental status, dietary, right? So there's so many things included on this form. It's also important that we update it. So as someone declines, maybe they go from being able to walk with a walker to not being able to walk and needing a wheelchair, or perhaps going from being able to get out of bed into a wheelchair with a transfer of assist of 1 or 2 to needing a Hoyer to get out of bed. So please make sure we update this. The next section will be our daily resident log information. We want to put the most recent in front so that it's really easy to read through like a book, so that the next person coming in can kind of know quickly what has happened. We should also be giving a verbal handoff, but this is a good way to kind of refer back. We should put our name at the top of each section that we're filling out. We should use this to document that we've turned or repositioned someone, if they've had a bath, if they've had a bowel movement, if they've eaten or drank anything. And sometimes this might not be relevant. If people are totally independent and we aren't turning and repositioning them, we know that, and that can be left blank. And then there might be other times where people aren't eating anything at all, so it would be left blank. The back side of the sheet is for the overnight, even though that's technically into the next day. I think that's how it works best. So the back side of the sheet will be kind of through that next overnight, and each sheet starts at 8 a.m. on that day. There's also additional notes and space for comments if there's anything, if you run out of space or have more to write, please feel free to continue on the back. Medications are really important. We have to be very responsible to make sure that medications aren't diverted from the house, that they are kept locked up and given only appropriately. So please know that tampering with them, using medications in any way that's not prescribed by hospice, or kind of losing meds is not acceptable, and we will investigate. So how we keep track of them is by using a medication record, as well as some other documents that we will go through. So this is the document that all medications that any resident would be on would be documented under, as well as how often it's ordered, how it should be given, what the dose is, all of that information. And then in each little box for each day of the month, we will document that it was given. So you would put the time that it was given, so 9 if it was 9 a.m. or 10 p if it was 10 p.m. And then your initials. So try and make that clear. These boxes are just barely big enough for all of that information. It's okay to round the time to kind of the closest hour or closest half hour if it's hard to fit that information in there, but it is really important to have our initial and the time that it was given. We will likely also use these sheets to have the hospice orders. So this would have more information about the medication that's being used. The top example, morphine sulfate oral liquid. So this is an oral liquid medication that's given out of a syringe. We'll talk more about that. It gives the dosage, it gives the frequency, so every 4 hours as needed. So you wouldn't give it every 4 hours, you would only give it if it was needed. And then that pain that medication is for either pain or shortness of breath. So it would have the information on there. So we want to be pretty careful with these things. Here's another example of that medication record and how we would fill it out. So it could either be time and then initials or initials then time. Either is fine. Next, we have our controlled substance count verification sheet. So this is in each record, and this needs to be signed by both the caregiver going off duty and the caregiver going on duty. So you would put the date, the time, acknowledge that the count was correct if it is, so you count all of the meds that are needing to be counted, so any controlled substances, and then both of you sign agreeing that it was correct at that time. This is how we can track if anything is missing or if people are not tracking things appropriately. That way we can kind of trace back and figure out who needs more education or what support might be needed to make sure that we're getting this correct. It keeps us accountable. So how would you know whether the count was correct or not? We have these narcotic administration records. This is where any controlled substance, so that could be an opioid pain medication, that could be lorazepam, that could be a few other things. Typically, we wouldn't have too many. It would be maybe 1, 2, or 3 different medications that we would be tracking, or potentially even tracking to make sure that comfort kit box was sealed. So this would be something that anytime you administered a medication, you would document that you had administered that medication and the count had been reduced by 1. So you would put the date, time, the starting count, if there was any added, and any subtracted because you gave that medication, and then the final count in your signature. If hospice comes and pre-fills more syringes or more pills are delivered via FedEx, we would then add those in as the added to count by hospice. So you add that number in, and either the hospice nurse, if they're here, can sign it, or you can sign saying that you added that number in. You can also always feel free to reach out to me if you are feeling uncertain about adding medications. We can also sometimes lock up more medications in the lockbox to make sure we have enough. This is really important to keep track of, and then we use this final count to, when we're counting at change of shift, make sure that the count is correct. A little bit more about medications. We want to keep the medications very safe and secure. We should close the caregiver room door whenever we are not in there. Sometimes it can be easy to leave it open. It's nice to be able to go back and forth, but especially if there's any visitors in the house or anything like that, we want to make sure that all the confidential information and medication should be locked away with the door closed. We also need to keep the cabinets locked and the refrigerator locked. So the medications should kind of be behind 2 sets of locks so that only those who are supposed to be getting into the medications can. If you leave the door unlocked and the cabinets unlocked and meds go missing on your shift, that is something that you would be held responsible for, and we would kind of have to make sure that we were tracking those things, so be really careful. We do almost always have additional medications stored in lock boxes. Right now our lock boxes are pink and blue. We may in the future get other colors, but if you are ever running low on a medication that's a controlled substance or are nearly out, keep in mind that we may have more. They're just locked up in the lock boxes. Both hospice and myself and anyone who would be on call in my role will have the code to the lock boxes to be able to get those out. Meds in the refrigerator should be labeled by room number or the name of the person, some way of knowing whose they are, since we only have one refrigerator. We can save the oral syringes for refill. They should be saved per medication per person so that we aren't mixing up medications and mixing up people. So there's almost always a second Ziploc bag for empty oral syringes. And then we should make sure that any identifying information on medication paperwork, bottles, shipping addresses, anything like that is either shredded or safely blacked out so that we're keeping information confidential. Only a couple more things. the hospice covering the resident is the only hospice that should be making recommendations or help with meds. So we may at times have 3, 4, or 5 different hospice agencies coming into the house because they each have a resident. It's really important to make sure that we're only taking recommendations from the hospice for that resident. We're never sharing medications, we're never sharing recommendations. We're not asking the hospice nurse to come and help us with care for someone that they aren't really involved with. Very important. They should also have these boundaries, but in case if something is getting mixed up, that's our responsibility. Any final notes about charting? So if you have any questions or concerns about the charting, if you feel like maybe there's been a med error, or you're not quite sure how to track something or quite sure how to give a med, please feel free to call me 24/7. We also really need to be keeping careful track of bowel movements, turning and repositioning someone, keeping track of what we're doing for fall prevention. These are all really important things to track and communicate with each other so that we can make sure we're caring for people appropriately. If there ever is any error or safety issue, we do have incident reports. Please fill out an incident report and also inform me at the same time. We may also need to report it to hospice depending on what has happened. So please be really mindful of that. And communicating with each other is super, super important across shifts, because there's a lot of people providing care, and anything we don't write down or document, it can look like it just wasn't done or wasn't thought about. So that also includes if someone refuses a medication, we should write down refused, not just leave it blank, because then it looks like someone forgot to give that medication, and that information gets lost. Next, we want to talk about a few care refreshers. We've probably gone over more than this in the orientation, or you may already have experience. We want to go over hand hygiene, administering sublingual medications and what that means, changing a brief and other personal care basics, and emptying a catheter bag. Hygiene is super important, especially in this, well, not especially in this setting, in any setting. Best practice is to sanitize our hands when we are entering and exiting a resident room. So we do have hand sanitizer in stations all around the home, so that you should be able to sanitize your hands as you walk into a room and as you walk out. Of course, if you have a huge tray of food, that might not be possible, but that is best practice, and we should be as consistent as possible with that. We need to wear gloves whenever we might come in contact with any sort of bodily fluids, bowel movement, blood, contaminants, urine, anything like that. If you're not sure, it's better to wear gloves. We never wash or reuse gloves. If you take them off, they're thrown in the garbage every single time. And then we should wash our hands after removing gloves every time as well. So washing our hands very frequently. Also wash your hands with soap and water before and after eating, working with food, or going to the bathroom. So all of these are best practice, and probably something that people are already mostly doing, but it is really important to keep on top of this, to keep all of the illness and everything clean and safe. So sublingual medications are medications that go into the cheek pocket or under the tongue. That is referred to as the sublingual space in the mouth, and absorbs medications really well. So these medications do not need to be swallowed. It's okay if they are, but they actually absorb very quickly through the tissues in the mouth. So the process is that you would wash your hands, make sure they're clean, make sure that a person's head is elevated or tilted to the side to avoid choking as much as possible. Then you would expel the medication from the oral syringe into the person's mouth, either under the tongue or in the side cheek pocket. They don't have to be able to swallow. They don't have to be able to be completely awake. So this is a really important way that we give medications when someone is nearing the end of their life. And then make sure you chart that medication very carefully, and wash your hands again. There are videos to go with these, but they don't seem to always be working. You can copy the link if you're able. Whenever we're changing someone's brief, we can go over this more in person, and there are lots of different videos online that could show you and demonstrate this for you. A few key things to keep in mind is that we want to raise the bed until it's at a good level for us. We want to protect our backs and care for people very safely. You can use bed rails to make sure that someone doesn't roll out of the bed on the other side if you're doing this alone, although ideally you would have a second person to help provide reassurance and keep someone safe. You should always wear gloves and wash your hands afterwards. And it's good practice to ensure that you have everything prepped at the bedside. So planning to have an extra set of sheets, extra pads, extra briefs, wipes, maybe a tub of warm water, all of those things before you get started. Right, next is the procedure to empty a catheter bag. Please feel free to ask for assistance, or again, Google or look on YouTube for additional information. We need to always wear gloves when emptying a catheter bag. Never bring the bag over the level of a person's bladder. If we need to raise the bed in order to get it high enough to drain, you can absolutely do that. Unclip and drain the bag into a urinal or other sort of tub or container that is used for that purpose. We want to do our best to avoid the drain tube touching anything, and then we can use an alcohol wipe to sanitize and clean the tube before clipping it back into place. All of these things can prevent UTIs and ensure that people are not having more complications or more issues than necessary. It is important to note that each and every catheter bag seems to be slightly different and have a slightly different method for opening and closing. And so it's just important to make sure that you've kind of double checked to make sure it is in fact sealed and clipped back into place appropriately before leaving. If there's any issue with that, you might just end up with some urine on the floor, which is then something to be cleaned up. Then we flush the urine and wash our hands, and we can move on to the next step of care. A few slides are a few potential challenges that we might experience in the house and what we would do in those situations. This is not an exhaustive list of the potential challenges, but might just give some ideas. Our in-person orientation and those slides have other incidents that we might discuss. So in case of feeling like you may need to call hospice, here's some ideas about like how and both when. So we can always call hospice. We often have to leave a message for the case manager or wait for a call back from the on-call nurse. Hospice does have someone who answers the phone 24/7, but that might be an answering service or a voicemail system or something along those lines, and then you would hear back from the nurse pretty quickly. If it's a non-urgent issue or not something that needs to be addressed that day, we can leave a note in the chart in the communication page for hospice, although sometimes that's not totally seeming to be effective, but ideally, they would be checking that for their weekly routine visits. We should call hospice anytime there is a change in a resident's condition. If they are no longer waking up or no longer seeming to be safe to take pill medications or not eating, or they have a new symptom or something like that, we should always call, even just to notify, not because we necessarily need anything from them, but they need to be aware. We can call them if there's any supplies or medications that we need. This also includes the durable medical equipment that we get, the hospital bed. If we need a different kind of wheelchair, or it seems like an air mattress would be better than the mattress that was delivered for them, or something like that, we can always call and have those discussions with hospice. We should always call if we have symptoms that are not controlled with the orders and medications that we have on hand. So sometimes that is that a person has more pain and we've already given the medications for pain and it's not time to give an additional dose, but they're still in pain. We should always call. Or it could be a new symptom. It could be that they've never had pain before, so we don't have an order, and now they are having pain. Ideally, we would have medications for that in a comfort kit, but we would need to call hospice in order to get approval to use those medications. And then finally, if the family or the resident has any concerns about their medical management, that is hospice's role, not our role, and we should notify hospice that they would like to discuss something, make a change, anything along those lines. I am also on call 24/7, or if not me, there will be someone available in my place if I'm on vacation. So please call or text. Everyone should have my phone number. Overnight, please call if it's urgent to wake me up. A text does not wake me up. Please only give my phone number to hospice and Harmony House caregivers. I don't want everyone having my cell phone number, but I think all of our caregivers should. Any sort of like non-urgent message, scheduling needs, equipment that we need, supplies that we need, things like that can either be emailed or texted. If you need more help caring for a resident than the care that you have in the home, so if we need a third set of hands sometimes, or there's a pretty big crisis, that's something I can either find someone to come and help or come and help myself. I should be called anytime a resident dies so that I can be part of that process, support you all, and help communicate with hospice. If there's any incident report that needs to be filled out, or you're not sure if you should fill out an incident report, I should be called. I need to know about them. I never want to have an incident report that I didn't hear about until I found it. If someone doesn't show up for a caregiver shift, please call me. If you need to call out or leave a shift early, or you're sick or something like that, please call. And then any other questions or concerns, that's why I'm available. Next is falls. It happens on occasion, hopefully not very frequently, that a resident may fall or may end up on the floor, even if it was a slow, careful, assisted fall to the floor. Please make sure that people are as safe as possible and as comfortable as possible. So that could be a pillow under the head, blanket to keep them warm. It's important not to try and move someone immediately. We don't want to panic and try and pick someone up. We don't know if they're hurt. We also don't want to hurt ourselves trying to move someone that we really shouldn't be. If you're able to move someone and get someone up very, very safely with the people in the house, that is fine. Otherwise, please call the Chicopee Fire Department and ask for a lift assist. The phone number for Chicopee Fire is posted around the house. And they can come and provide an extra few sets of hands to get someone back into bed and comfortable. If there's any kind of injury, please call hospice immediately to come for an assessment. We should fill out an incident report and then document that carefully as well. Finally, when a resident dies, we've talked through this in a few other places, but I think it's good to have it as a reminder here. The process would be to call hospice and ask for a nurse to come pronounce. Hospice is then responsible for informing family of the time of death and information about death. They can assist with post-mortem care and cleaning someone up, getting them dressed the way that they would like. They are responsible for destroying medications. They start the process for the death certificate, then that gets completed by the funeral home. And they may be the ones to call the funeral home, unless if the family wants to or is asking for some time, and then we can help with that. Please always call me if there is a death, and I can help in any way possible. All right, thank you so much. I hope this is helpful.